Good morning, everyone.
Good morning.
Excellent to see so many people turning out at 6:30 a.m. on a Tuesday at Chest. Hopefully you've all had your coffee and you're feeling invigorated. We have what's hopefully going to be an exciting and interesting session for the next hour. We're going to be talking about fibrosing interstitial lung disease. I have esteemed colleagues with me. We have Maher Castelino and Kevin Flaherty, and myself, Toby Maher. And we are going to be talking about various topics related to fibrotic interstitial lung disease. There will be an opportunity to interact, and I'll come back to that in a second, but use your devices to post questions because we want to make this as interactive as possible. We don't want to just be giving lectures. These are just some reminders. So this is a session that's been developed by PeerView, although Boehringer Ingelheim provided an educational grant for the symposium. If you haven't already done it, please complete the pre-event survey. There will also be polling that goes on during the presentation. If it asks if we're brilliant, then please put yes. I don't mind what other answers you give, as long as you're nice about us. As I've already said, submit your questions and answers on the app so that we will see them on the iPad up here. And then you'll also see that there are polls to respond to. And this, if you haven't already done it, is the QR code to scan so that you can use the online thing for putting up questions. As you might already have heard, there is a $50 prize for one person in the room who uses this, and apparently the more you use it, the more likely you are to win. So that's an exciting challenge for you all. And then you can view the slides, practice aids, download them after the event. So there's more interactive material that you can use if you want to. And then the way the session will work is that we have some slides we're going to talk through. So there will be a lecture component to this morning. But there will also be a sort of town hall element where we will, between the three of us, try and address answers to what we see as critical questions. Some of these questions came up at previous similar meetings, so hopefully you'll all agree that they're relevant topics for discussion, but it'll be an opportunity for some back and forth. And then these are ultimately the goals. This is what we hope you will take away from the session, understanding the importance of fibrotic interstitial lung disease, understanding how to diagnose it accurately, and appropriate referral pathways, and then a focus on multidisciplinary patient-centered management of fibrotic interstitial lung disease. And then these are the gaps that have been identified. So again, there have been a number of surveys to try and understand where the needs are for our patients with fibrotic interstitial lung disease. And you can see here on the various bullet points some of the key highlights of different studies that have been undertaken. There does seem to be a delay to identifying patients with interstitial lung disease. There's this lag time of almost 8 months between first symptoms and them ultimately seeing a pulmonologist who's in a position to deliver care. Even when they get to see the pulmonologist, there is often a delay in actual making of the ILD diagnosis, and frequently there is misdiagnosis. Patients are often told they have COPD or asthma. Again, in another survey, there was the suggestion that patients aren't undergoing the right investigations, either to diagnose their ILD or to ultimately monitor it, and that's something we will address. And then we already recognize from the last decade of having antifibrotic therapy with pirfenidone and nintedanib that not all appropriate patients are being offered treatment. So again, that's something that we will seek to address. So that's the plan for the next, what is going to be 55 minutes. But first up, Kevin Flaherty, who really needs no introduction. He's been doing ILD for longer than I've been a doctor at this stage, Kevin.
Thanks, I think.
Kevin is from Michigan, so he's made the long journey here to Chicago, and he's going to tell us a little bit more about fibrotic ILD.
Thanks, Toby. So this is that first town hall portion of the symposium. These, as Toby said, are questions that were submitted ahead of time or from other ones. And so the first question, persistent dyspnea is common in many respiratory conditions. What clinical clues help distinguish fibrosing interstitial lung diseases from COPD, asthma, or cardiac causes? I think getting at that unmet need of the misdiagnosis of the diagnosis. So as you guys sit here and think of the patients you see, maybe referred late or maybe on time, what are the clinical clues that we can try to convey to the primary care audience, our colleagues, about finding people sooner rather than later?
I think from my perspective, ILD has a very typical history of breathlessness. So it's breathlessness on exertion. It comes on relatively rapidly, so it comes on over weeks to months. It's not years or longer like COPD. It tends to be a fairly fixed symptom. Patients don't have good days and bad days. They just have exertional breathlessness that doesn't vary in the same way that it does with airways disease. I think there is a challenge with cardiac disease and distinguishing ILD from early cardiac disease because there's often an overlap in risk factors. But I think that's where the clinical examination then becomes important because things like finger clubbing and bilateral basal crepitations really are the giveaway that this is going to be an ILD and not a cardiac disease. So I think clinically, even before you've done any tests, there are often clues there.
Great. I think the other symptom is cough. So they have that dyspnea, and it's a dry cough. It's not variable like it might be with asthma or COPD. A patient I saw a couple weeks ago, unfortunately, his partner's parent died from pulmonary fibrosis, and she got him in to see pulmonary because she says, I recognize that cough. And so the cough is another thing that can clue you in. But I think the other point you make that is really, I try to talk to our students and residents about, is listen hard for crackles. Really listen hard, and when those show up, that really tips you towards, I need to be thinking about interstitial lung disease. Second question, is PET-CT appropriate in the diagnostic workup of interstitial lung disease?
I know.
I feel like so in control right now.
And I don't want to steal everything, but there are very specific cases where PET-CT might be appropriate, but I think in 98% of patients, it's not a test that we're going to do. I think there is a role for PET-CT in patients with sarcoid with multi-organ involvement, where you want to look beyond the lung to see the pattern of organ involvement, particularly if you suspect cardiac involvement. Clearly, there is a relationship between fibrotic ILD and malignancy. So again, if you suspect malignancy in an ILD patient, it may be appropriate to get a PET-CT, but it's not part of the standard workup for your average ILD patient.
Agree. We've talked about not everyone getting pulmonary function studies. We think of restrictive physiology with reduced FEV1 FVC and a normal FEV1 FVC ratio. In terms of DLCO, measuring how efficiently oxygen can get into the bloodstream. And I think it's critical we follow it as part of the progression of our patients with ILD. But I think the other thing that DLCO can tip us off is our ILD patients that then develop pulmonary hypertension, where you see more precipitous or disproportionate drops in DLCO. So I think it is important to measure DLCO both as part of our diagnostic, but also following patients over time with their disease course. Cryobiopsy is interesting, the role of cryobiopsy. My take on cryobiopsy is it's very center specific. If you are at a center that does lots of cryobiopsies, it's probably a very good test to consider for those patients that need a surgical type biopsy at your institution. Michigan, we don't do cryobiopsies. It's just not something we do. So if we're going to think about histopathology, we're going to be sending them to thoracic surgery for a minimally invasive thoracoscopic procedure. Are you guys a cryobiopsy site or?
And we have a couple of interventional pulmonologists who've been doing it for the last few years, who are very experienced at it, and we also have a pathologist who's very happy to interpret cryobiopsy. I think the important thing to say about cryo is that it shouldn't be changing our threshold for doing a biopsy. We should still be, asking ourselves the same questions in MDT about whether a biopsy is necessary to make diagnosis and whether it's going to ultimately change diagnosis and management of the treatment. But if you've made a decision to biopsy, then in many cases a cryo is an appropriate, less invasive way of doing it. I would say for cystic lung disease, I still go to surgical biopsy. But for sort of diffuse fibrotic interstitial lung disease, if I'm going to do a biopsy, I would go cryo first.
Excellent. Mass General, we're doing the same. I'm a rheumatologist, so I only have experience from my pulmonary colleagues, but cryobiopsy is being done.
Yep. All right, so how is systemic autoimmune-related ILD differentiated from idiopathic pulmonary fibrosis?
So I'll take this one.
Yeah,
You have that one, yeah.
So in terms of SARD ILD, so what we're looking at is for an underlying rheumatic disease, so trying to tease out, one, symptoms of inflammatory arthritis, presence of Raynaud's, for example, as we're thinking about scleroderma ILD, looking for skin tightening. The antibodies can be significantly helpful in determining SARD ILD. So making sure you send an anti-nuclear antibody and the specific extractable nuclear antigens, and then as well as a rheumatoid factor and a CCP antibody. Those are a good start in terms of evaluating for SARD ILD.
Should we just say for the room quickly, for those of you that don't keep up with the rheumatology literature, SARD ILD is what we were calling CTD ILD until a year ago, and then the rheumatologists in their infinite wisdom decided that SARD, which is systemic autoimmune rheumatic disease, is a better term than CTD, connective tissue disease. So we're stuck with SARD ILD, thanks to our rheumatology colleagues.
A related question along those lines, maybe now thinking as a rheumatologist, I'm talking pulmonologist, but as a rheumatologist, you're probably going to see the people with SARD first in most cases. When do you, as a rheumatologist, think about screening for ILD? Because it's not everybody, so how do you determine, how do you screen and which patients do you screen?
Yeah, so typically our patients with systemic sclerosis and myositis, we do baseline screening on those patients. In rheumatoid arthritis, and we'll screen with PFTs and a high-res CT. In terms of rheumatoid arthritis, we try to think about other potential risk factors, so having high titer serologies, for example, that may put them at risk for ILD. But the practice is mixed in rheumatoid arthritis. I think we have a better screening platform in terms of myositis and systemic sclerosis.
Great, thanks. All right, so that ends town hall number 1. We'll come back with other questions as we move through this program. And also, please remember to be asking us questions so we can get questions throughout as well as at the end of the session. So what is interstitial lung disease? So it's a heterogeneous collection of over 100 different distinct disorders: idiopathic pulmonary fibrosis, autoimmune-related, hypersensitivity, idiopathic. We talked already about the symptoms, which are common and nonspecific. So cough, shortness of breath, and fatigue are the 3 most common symptoms. You can imagine how hard that is in a primary care audience, seeing so much cough, fatigue, dyspnea, and then trying to sort out, is this ILD or more common things like cardiac or COPD or asthma. And we talked about the character of those symptoms and how they're presenting, and then listening hard for crackles as a way to try to tip the point towards more of an interstitial lung disease continuing workup. With pulmonary function studies, these diseases are usually restrictive in physiology. The scars contract, the lungs get smaller, so we have restriction with smaller F values for FVC and FEV1 without an obstructive ratio, and DLCO, the ability to get oxygen into the bloodstream, is also decreased. Toby talked on earlier the delay in diagnosis with patients progressing often even longer than a year with symptoms, and then during the next year through evaluation being misdiagnosed along the way. And the sad point is, although we have therapies now, and we're getting new therapies, which is really exciting, our therapies are primarily slowing the disease course. We aren't stopping or reversing yet. So the longer we wait to initiate therapy, the more irreversible fibrosis and lung damage has time to progress. We constantly are changing things. We talked about SARA-ILD, and now we're talking about the newest guidelines on the classification of interstitial pneumonia. So these came out a couple months ago. And here we're talking in our session about interstitial lung disease, and we're already wrong. Our new term is supposed to be interstitial pneumonia. The reflection based on, that is probably a better term, reflecting that there are interstitial components, but also alveolar or ground glass or pneumonia patterns. So interstitial pneumonia is felt to reflect a better terminology of both interstitial and alveolar patterns in these diseases over the term interstitial lung disease. We've always, in talking about diagnosis, talked about the importance of the history and the exam and the lab evaluation, that detective work to find the cause and then put that cause with the pattern of CT or histopathology. Same idea, although it kind of flips a little bit in these guidelines where you're almost starting with what is the pattern. For instance, a pattern on a CT scan of usual interstitial pneumonia and then putting it in the context. Is that UIP pattern idiopathic? We'll call that idiopathic pulmonary fibrosis. Or is it in the setting of rheumatoid arthritis? And we'll call it RA-UIP. One of the hottest aspects of discussion from the guidelines was a new pattern, or putting a name around a pattern that we've been seeing for decades, called bronchiolocentric interstitial pneumonia. This was actually fairly contentious, and four of the authors actually recused themselves from being authors because of the inclusion of this pattern. This is a pattern that we used to call hypersensitivity pneumonia. You could have non-fibrotic or fibrotic, but there were areas of air trapping, some ground glass, some fibrosis. It was heterogeneous across the CT. And the problem with calling that HP is, yes, there were patients with HP that had that pattern, but this pattern also was in patients with connective tissue disease. And it was also present in people where we couldn't find an autoimmune disease or an antigen, and it was more idiopathic. So I think this is a pattern that we've looked at, called it different things over the years, primarily hypersensitivity pneumonia, even if that wasn't the cause. Now we have the opportunity to study this, find this pattern, and see how it progresses over time. Similarly, are these patterns, say non-specific interstitial pneumonia, is it primarily fibrotic or non-fibrotic? And then using Chris Ryerson's confidence, how confident are you in your MDD diagnosis? From over 90% confidence, it's a slam dunk, this is IPF, to boy, I'm not even 50-50 sure. I think this might be fall more in terms of an unclassifiable. So kind of the highlights of the guidelines that were published in August of this year. And again, these are just, as things became more complex, thinking of interstitial patterns, alveolar filling patterns. Is it secondary or is it primary? We talked already about when to suspect interstitial lung disease: dyspnea, cough, fatigue, listen hard for crackles. If those are present, do joint exams. If you see skin thickening, swollen joints, order pulmonary function studies looking for a restrictive pattern, chest x-ray, which is really, I think, just a warm-up for an HRCT scan, and then hall walk tests. The diagnostic algorithm, at least for IPF, first, we suspect it. We look for other causes. I think of that as putting your jury hat on. Beyond a reasonable doubt, can I find a cause? If I can't, I'm thinking it's idiopathic. I'm going to look at the CT scan. Does that CT scan show a pattern of definite or probable usual interstitial pneumonia? If it does, I've got a diagnosis of IPF. If it doesn't, what other tests do I need to perform? Do I need more detailed serologic testing? Do I need a rheumatology consult? Do I need to do a transbronchial cryo or a surgical lung biopsy to help me figure out what the final diagnosis might be? Is it IPF or something else? And now I'm going to pass the baton. There you go.
Okay. All right, so let's talk a little bit about the various SARD-ILDs, and the term is catching up with us as well in rheumatology. So in terms of the more common rheumatic diseases associated with ILD, systemic sclerosis is really the leading diagnosis. We additionally see it in mixed connective tissue disease, rheumatoid arthritis, as I mentioned, and then inflammatory myositis. I would say that those are the top conditions that we see associated with ILD. We do see it in Sjogren's, but I would say that in my clinical practice, it's much lower compared to these other diseases. So what's the difference between SARD-ILD and IPF? So again, we're thinking about multi-system involvement in SARD-ILD. So again, looking at joint inflammation, skin involvement, muscle inflammation as well. And then the specific antibodies can also be helpful in differentiating SARD-ILD from IPF. The pattern that we typically see is the NSIP pattern across the board for the different SARDs, except in RA-ILD where there's more of a UIP pattern. And the disease course can vary depending on the underlying rheumatic disease with quite a variable progression. One important thing to remember with SARD-ILD is usually they're responsive to immunosuppression and we can stabilize disease. While idiopathic pulmonary fibrosis, there isn't really there's a lack of response to immunosuppression. So shown here in these CTs are the two different patterns that we see. So on the left is the nonspecific interstitial pneumonia pattern, and then on the right is the usual interstitial pneumonia pattern. And you can see, as I mentioned, so systemic sclerosis, the inflammatory myopathies, MCTD, Sjogren's are more associated with this NSIP pattern. I don't know if this pointer is working. Oop.
Oh, it's the mouse.
Oh, okay.
There you go.
So here's just some evidence of ground glass opacities in the periphery. As a rheumatologist, I should not be reading CTs for the
You're
pulmonary
doing phenomenal.
audience.
You're doing great.
And then on the right here is the usual interstitial pneumonia pattern, so more honeycombing that we'll see in rheumatoid arthritis, ILD, as well as obviously idiopathic pulmonary fibrosis.
You did a much better job than me doing a skin score.
All right, so before we move on, just take a moment to answer this follow-up poll on identifying fibrosis ILD. All right, so let's move on to the next question. So fibrosis is often described as a self-sustaining process. What do we know about the mechanisms that perpetuate progression even after the initial trigger?
I'll leave it to you.
I'm where to start. And we could discuss the pathogenesis of fibrosis all day, but we know essentially that what drives fibrosis is an aberrant wound healing response, that everything that's involved in normal wound healing is involved in the development of fibrosis, but rather than the process resulting in resolution, it results in this progressive scarring. And so we know that once these pathways are activated, you get sustained release of growth factors like TGF-beta that tend to perpetuate the fibrosis. But not only that, as the collagen makeup of the lung changes and the lung becomes stiffer, those in themselves seem to become triggers for development of further fibrosis. So you end up in this situation where you remove the sort of initial trigger for the fibrosis, and that could be the bird exposure with the hypersensitivity pneumonitis. It could be treatment of the systemic autoimmune rheumatic disease, but you do that and you still see the lung fibrosis getting worse. And our assumption is it's because of that, change in lung stiffness, activation of pathways, that we see the fibrosis continue independent of the cause.
Great, thank you.
Yeah, I agree. I think there's also the potential of other comorbidities, reflux, for instance, triggering a flare-up again, the systemic autoimmune disease that's been treated but then backed off on immunosuppression, but then it flares again and drives it. So I think sometimes you can have those initiating factors in the background on top of the perpetual fibrosis that kind of flare things up again and start that cycle over and over again.
Yeah, and I think infection is also another one of those factors.
So this schematic here summarizes what we've discussed. So in terms of some initial tissue damage leading to activation of the inflammatory cascade, and then there's aberrant epithelial activation down here. This ultimately, as Toby mentioned, results in activation of the TGF-beta pathway with migration and proliferation of fibroblasts, and then conversion of fibroblasts to more of a myofibroblast phenotype and ultimately resulting in fibrosis. And there's 4 drugs now approved for treating ILD. So nintedanib, blocking more the tyrosine kinases, so affecting fibroblast proliferation and angiogenesis, and then pirfenidone, which modulates TGF-beta and reduces fibroblast activity. Tocilizumab, which we use a lot in rheumatology, inhibiting IL-6, so one of the cytokines here, and ultimately affecting fibroblast activation and fibrosis. And then the new drug, nerandomilast, an oral PDE4B inhibitor, which has both immunomodulatory and antifibrotic properties. We'll get into more detail on that later on in the talk. One of the key things to remember with all ILDs is that these diseases progress. And the exciting ILD registry in Europe looked at the various phenotypes of ILD, and you can see in these graphs that there is progression across the spectrum of ILDs. And then the American Thoracic Society and the European Respiratory Society has defined progressive pulmonary fibrosis. So in order to be defined as progressive pulmonary fibrosis, in a patient with ILD of known or unknown etiology other than IPF, at least 2 of the following 3 criteria are needed. So worsening respiratory symptoms, any physiological evidence of disease progression based on PFTs, so a decline in FVC of more than 5% within 1 year of follow-up, or an absolute decline in DLCO of more than 10% within the year, and then evidence of radiologic disease progression. And up to 30% or so of patients with non-IPF fibrotic ILDs will develop progressive pulmonary fibrosis, usually within 60 to 80 months of symptom onset. All right, so before we move on, you can go ahead and answer this polling question. And just remember, you've got to be in it to win it. All right, I'll turn it over to Dr. Maher.
Thank you.
Great job.
Right, good. So yeah, remember, as well as answering questions, you can ask questions as well for us to discuss later on this morning. So, a bit more town hall. Patients with which autoimmune disorders would benefit most from early administration of nintedanib? Flavia, this goes to you initially.
So I think I primarily focus in systemic sclerosis, and I do think there's a clear indication for nintedanib, but typically we do start with immunosuppression first in our patients. So we'll put patients on mycophenolate, and then if they're continuing to progress, then we'll typically add nintedanib. I will note one of the challenges, especially in systemic sclerosis, is the diarrhea effect, as patients with systemic sclerosis already have gastrointestinal involvement, so it sometimes is a challenge to administer nintedanib.
Yeah, our approach is similar to start with immunosuppression because of the side effect issues. Even though you do not have to wait for progression to use nintedanib in systemic sclerosis, usually we do, or at least maybe not all the way to the progressive criteria, but some sign that the disease needs something to help with the fibrosis, mostly because of the side effects it's harder to tolerate.
Yeah.
And the second question is there a role for prophylactic therapy in scleroderma ILD to reduce lung injury?
That's a challenging question. I mean, we're doing screening early on, and I think if there are signs of early ILD based on the PFTs, and also if they have extensive skin involvement, then we are putting them on a treatment pretty early on. And I think it's also important to think about systemic sclerosis in terms of the diffuse subset, which is the more aggressive one that does develop ILD, compared to the limited subset of disease. So we're factoring in many things in terms of determining the treatment approach for SSc-ILD.
Yeah, and I certainly think it's the way we should be going in the future.
Yep.
I think we should be designing trials to see if we can actually prevent ILD by early aggressive treatment, but we just don't have the evidence, do we, at the moment? We have some more questions. Can antifibrotics be used in conjunction with immunosuppressive agents, Kevin?
Yeah, so the hard part is tolerability, but definitely in people with autoimmune disease driving their interstitial pneumonia, a combined approach for the immunosuppression trying to treat the underlying inflammatory component. And then, as you mentioned earlier, in terms of progression and fibrosis, that fibrotic part of it can become its own self-driving force, so using antifibrotics to help with that fibrotic progressive component, try to slow that down. So really a two-pronged approach, looking both at treating the underlying inflammatory aspects, but also the fibrotic damage that's continuing.
And Flavia, would you say there's a potential role in some patients for combination nintedanib tocilizumab?
I think in a very certain subset of patients. So one of the things with the tocilizumab study is the study looked at patients with early systemic sclerosis, more of an inflammatory phenotype. And when we're thinking about nintedanib, it's more, progression of pulmonary fibrosis. So there is a small subset of patients that we do use the combination with.
So what is the long-term prognosis for patients treated with an antifibrotic agent, Kevin?
Better than those not treated. And I think we've learned that over the past 10 years. I mean, our antifibrotic use is not completely utilized, usually because of side effects and tolerability issues. Hopefully that'll get better as we move into the new treatment era. But I think the past 10, 11 years have showed us through registry data and personal experiences that patients that are able to be on therapy do have slower decline in lung function and they live longer. So I think the long-term prognosis is better with or without, with treatment than without therapy. The second question there about predicting response is also hard, right? So you kind of take it with faith that the patient is still progressing on an antifibrotic, but they would likely be progressing more quickly without the antifibrotic. But it's hard without a biomarker to prove that it's working. That may be part of the reason that patients fall off therapy is not feeling or having proof of the benefit. If you're a diabetic and your blood sugar goes down, yeah, it's working. You're treating hypertension, my blood pressure is better, yeah, it's working. But we don't have that type of measure in a disease that still gets worse over time, although it gets worse more slowly.
Yeah, and I agree. I think it's one of the challenges. And that leads on to should antifibrotic therapy be given to patients with advanced fibrotic lung disease? I'll give a quick answer, spare you, Kevin. I think the answer is yes, but clearly the risk benefits change as disease advances. And what we're trying to do with treatment is slow progression. We're not ultimately preventing or reversing it. And I think the data that are available would suggest that probably the patients that benefit most are those with the least fibrosis and the well-preserved, best-preserved lung function. But that's not to say that patients with advanced disease don't derive some benefit. It's just the magnitude of that benefit is smaller. So I think when discussing the pros and cons of treatment with patients, if they've got severe disease, they're on oxygen, you need to be realistic about what treatment is going to offer, and I think have an informed discussion with the patient about the pros and cons of starting therapy. Right, so to get on to some lecture slides. So we've heard a little bit about the concept of progressive pulmonary fibrosis, and certainly that informs our therapeutic strategy. The reason that IPF is not included in the definition of progressive pulmonary fibrosis is because it is a disease that progresses, so it already is the archetypal progressive pulmonary fibrosis. And as I've alluded to, I think if you diagnose IPF, you should be thinking about starting patients on treatment as early as possible. But for patients with non-IPF ILDs, we're probably going to want to treat the underlying disease itself. So with the SARD ILDs, we are probably going to start treatment directed at the systemic autoimmune disease. But we are going to monitor these patients, and if they develop progressive fibrosis, then we're going to consider them for treatment with antifibrotic drugs. As we've already heard about, there are a number of drugs now approved for treatment of fibrotic interstitial lung diseases. I'm not going to go back through this in detail. Everyone is going to be very comfortable with nintedanib, pirfenidone. We've had those for a decade. Tocilizumab has more recently been approved for scleroderma ILD specifically, and then in the last week to 10 days, nerandomilast has been approved as a treatment for IPF. These are the recommendations from the ATS-ERS treatment guidelines for IPF. Of course, they're already out of date because they predate nerandomilast. But if you look at the left-hand box here for treatment considerations, the guidelines suggest thinking about pharmacological therapy for patients with IPF. We've added nerandomilast. There are also the non-pharmacological treatments, oxygen, pulmonary rehabilitation. There's the treatment of comorbidities, so pulmonary hypertension. We've already talked about gastroesophageal reflux, obstructive sleep apnea and lung cancer. And of course, there remains, unfortunately, an important role for end-of-life care and symptom management. And then, of course, we're going to monitor our patients for progression, disease complication, and sort of evaluate their need over time for things like lung transplantation and palliative care. Flavia's going to address the next two slides because it's too complicated for me to talk about SARD-ILD.
I guess I can take it from here. So last year, the American College of Rheumatology and CHEST developed treatment guidelines for SARD-ILD. And the schematic just shows the first-line treatment for systemic sclerosis myositis, mixed connective tissue disease, and rheumatoid arthritis. And across the board, mycophenolate is actually considered first-line for each of these conditions. In certain diseases, for example, with myositis, azathioprine may be considered as first-line, or rituximab, depending on the patient profile. And even in rheumatoid arthritis, if a patient has more significant joint involvement, something like azathioprine or rituximab may be preferred over mycophenolate. In terms of steroids, so in systemic sclerosis, glucocorticoids are strongly contraindicated, so no steroids in systemic sclerosis. However, we do use it initially in the treatment of myositis, mixed connective tissue disease, and rheumatoid arthritis. And then what about those patients that may progress after their first ILD treatment? So then typically we will add or switch therapy. So again, it was difficult to come to a leading next line treatment, but considerations in systemic sclerosis, if a patient has been on mycophenolate, for example, in certain subsets we might add rituximab, nintedanib, or tocilizumab. And in the myositis, mixed connective tissue disease, and rheumatoid arthritis, rituximab is considered for each of those conditions. Calcineurin inhibitors are also used in myositis. In rheumatoid arthritis, if they have more predominant joint involvement as well, we might consider tocilizumab, even though it's not necessarily indicated for RA-ILD specifically and is only approved for systemic sclerosis ILD. One of the key things here in terms of progression of ILD, long-term glucocorticoids are not indicated for really any of these conditions.
Thank you. And my take-home from this is that as pulmonologists, we need more exciting treatments so that we can have longer lists in our guidelines as well. But anyway. Right, another opportunity for you to answer a question. Remember, got to be in it to win it. $50 might just afford you a cup of coffee here. Right, so unmet treatment needs in progressive pulmonary fibrosis. As of today, nintedanib is the only antifibrotic therapy that's approved for the treatment of progressive pulmonary fibrosis, and that was based on the results from the INBUILD trial. Pirfenidone, although it's been tested in unclassifiable ILD and rheumatoid-associated ILD, is still only approved for IPF. And although we know that nintedanib slows progression, we also know that despite having antifibrotics for a decade, our patients are still dying from respiratory failure. So there's clearly a huge unmet need for new treatments that will hopefully provide better efficacy and fewer side effects for our patients. And so that was really the rationale for the Fibroneer trials that I'm now going to talk to you about. So you've already heard about nerandomilast, which is a PDE4B, phosphodiesterase 4B inhibitor. The phosphodiesterase pathway plays a role in both inflammation and fibrosis. We've seen PDE4 inhibitors used for other indications. So roflumilast is approved for COPD. There is also a PDE4 inhibitor approved for psoriasis. But the problem with those drugs is that they've had a lot of gastrointestinal side effects. Nerandomilast is designed to be specific to the PDE4B receptor, which is not found in the gut, and therefore the goal with nerandomilast when it was being developed was to provide the benefits of phosphodiesterase inhibition without all the side effects associated with pan-PDE4 inhibitors in the past. And so the FIBRONEER trials were two trials, one that was run in IPF patients, another that was run in patients with progressive pulmonary fibrosis, so the FIBRONEER ILD trial. The design of these studies was almost the same. So patients were randomized 1:1:1 to either nerandomilast 18 milligrams, nerandomilast 9 milligrams, or placebo. The primary endpoint was measured at week 52, and that was change in forced vital capacity. And patients stayed in the study until the final results were known. So there was actually a longer period of follow-up to give us more indication about the effect of treatment on things like hospitalization and mortality. And the only real difference between the trials was the background treatment that was allowed. So for IPF, patients could be on pirfenidone, nintedanib, or nothing at all. For the ILD study, because pirfenidone is not indicated for PPF, patients could only be on nintedanib or no background treatment. And these are the results from the IPF study. So if we look at the graph on the left-hand side, the orange bar is the placebo patients. As you can see, the placebo group, even though 80% of them were on background antifibrotic therapy, lost about 180 milliliters of FVC over 52 weeks. And you can see that both doses of nerandomilast were associated with a slowing in that rate of FVC decline. And remember, the reason we think that FVC is important as an endpoint is that it's ultimately a surrogate for mortality. If you can slow down FVC decline, the expectation is that patients will live longer. And on the right-hand side, you can see the change in FVC over time. And then this is the data from the ILD study. So this is patients with progressive pulmonary fibrosis. So again, if we start on the left-hand side, you can see that the rate of FVC loss in these patients with progressive pulmonary fibrosis is very similar to what we see in IPF. So this is a disease that progresses inevitably, and you can see that there's a very clear treatment benefit with both doses of nerandomilast. Again, if you look on the right-hand side, you see the FVC over time. It's worth saying that the reason that this looks more impressive in the ILD study than the IPF study is because in the IPF study there was an interaction with pirfenidone that reduced the plasma exposure of nerandomilast. So in the IPF study, the patients who were on the 9 milligram dose of nerandomilast and pirfenidone didn't get any treatment benefit. And that wasn't a problem in this study because there were no patients on background pirfenidone. So you get a much better impression of the efficacy of nerandomilast in these patients. And then this is also data from the ILD study showing the effect of treatment on those important secondary endpoints. So a composite of hospitalization, acute exacerbations, or death. So the first two bars on the forest plot up here are the composite key secondary endpoint. And you can see, although it doesn't quite reach nominal significance, the p-value is 0.06, so very close to showing effectiveness of the highest dose in reducing hospitalization, acute exacerbation, and death. And then when we look down at the different components, if we look at the bottom here, nerandomilast has a clear benefit at both doses on the risk of death. In actual fact, this hazard ratio of 0.48 for the 18 milligram group means that nerandomilast is halving the risk of death in patients on treatment compared to the placebo group. And then safety is obviously important. I think the key take-home from this is that nerandomilast looked to be much better tolerated than nintedanib or pirfenidone. There were no excessive dropouts in the active treatment group, which is what is very different to what we saw in the pirfenidone-nintedanib trials. There was a slight increase in the rate of diarrhea, particularly in the patients who were already taking nintedanib. For patients who were just on nerandomilast alone, there were a few relatively mild diarrhea events, but none that led to a significant discontinuation rate. Again, this reiterates the same point. ILD looked the same as IPF. So, another question. And then just to sort of wrap up, there are other treatments in development. So excitingly, I think over the next 5 years or so, we will hopefully see more treatments becoming available. It's been a bit of a challenge that it's taken us a decade from pirfenidone and nintedanib being approved to now seeing nerandomilast approved. Hopefully it won't be another decade before the fourth treatment is approved. There are 3 drugs that are close to a potential approval. So there's admilparant, which is something called an LPA receptor 1 antagonist. The LPA pathway is important in driving the fibrotic response of fibroblasts. Admilparant is in a phase 3 trial, and we expect data from that probably at the end of next year or the beginning of 2027. There's also inhaled treprostinil. So treprostinil, Tyvaso, is approved as a treatment for pulmonary hypertension related to pulmonary fibrosis. We saw data from the first of the phase 3 trials of treprostinil as an antifibrotic drug presented at the ERS 2 weeks ago. And that study was positive, suggesting that treprostinil also slows the rate of FVC decline. There is a second study that we're expecting to read out sometime next year. And if that is positive, we can anticipate that treprostinil will be approved both as an antifibrotic drug and as a pH drug. And then there's a program to develop inhaled pirfenidone, so a way of trying to get pirfenidone into the lung whilst avoiding all of the systemic side effects that we associate with treatment. So in summary, I think over the last 45 minutes or so, we've hopefully convinced you that fibrosing ILDs are a very important problem for our patients. They are life-limiting conditions. There are major unmet needs, both in terms of identifying and diagnosing these conditions, but also in treating them. Our treatment up until now has helped. It has slowed disease, but it hasn't prevented it. It doesn't prevent the development of respiratory failure or death. I've shown you that IPF is not the only important condition we should think about treating, and we've talked about some of the novel antifibrotic drugs, including nerandomilast, which has just been approved as a treatment for IPF. So we've got, I think, a few questions have come through already. If you've got more questions, then please put them online, and we can go through them. But right, I will try and read the questions. So here, Flavia, one for you. How often should you repeat autoimmune blood work if only one test comes back positive, e.g. ANA, in a patient suspected of having autoimmune disease?
So usually if the ANA is positive, I will do more specific antibodies, so I'll do the different extractable nuclear antigens. We typically tend not to keep repeating the antibodies unless there's a change in symptoms. So I think it's important if there is a positive ANA that's of a good titer, that the patient still continue to follow with the rheumatologist to see if there's any subtle development of a rheumatic disease.
And I guess the follow-up from that is, does strong positivity of one autoantibody shift your thinking diagnostically away from IPF if all other clinical workup is negative for systemic autoimmune rheumatic disease?
So I think if there is a positive antibody and they're not having any other clinical features of a rheumatic disease, we sometimes do put them into that category of IPAF. So having autoimmune features with ILD. And in some cases, those are treated similarly to as if they had a rheumatic disease, but they're watched closely with both the pulmonologist and the rheumatologist.
Fine. And then I think for both of you, or for all of us, in actual fact, I can answer as well, I guess. When there is progression of disease in SARD-ILD, how do you decide if you switch immunosuppressive drugs, add immunosuppressive drugs, or add antifibrotic drugs? Simple.
Yeah.
Do you want to go
So from a
first, or-
pulmonary
yeah.
perspective, it's easier for me because I'm going to think about adding an antifibrotic, particularly if there's evidence of progressive fibrosis on HRCT or worsening restriction. I think the role around immunosuppression, curious your thoughts, adding additional switching probably depends some on tolerability and other factors.
Yeah, so really it depends on, one, have they tolerated the first drug. We sometimes do add, for example, rituximab onto mycophenolate or tocilizumab onto mycophenolate, but watching their blood counts closely. It really depends on what other rheumatic symptoms they're having, how we're trying to get that aspect of their disease controlled. But we can use combination, I guess, immunosuppression therapy with close monitoring of the labs.
And I guess when I talk to rheumatologists, there is sometimes discussion about using immunosuppressions that target different limbs of the immune system. So obviously rituximab is going to be B-cell targeting. Tacrolimus and the calcineurin inhibitors maybe a little bit more B-cell focused. So there's perhaps more logic to some combinations than others, isn't there?
Yeah, at our institute, I feel after mycophenolate, we do tend to go to B-cell depletion. IL-6 inhibition, for example, we'll only use it in a subset of patients with RA and the early systemic sclerosis. So we are thinking about the underlying pathogenesis of the rheumatic disease itself, and then trying to decide what's the best immunosuppression to give next.
I guess the other question is how often do you factor in, so we're talking about these as systemic diseases, the scenario where, boy, it seems like the rest of the body has behaved, all right, the joints are no longer on fire, the patient's walking better, the renounce may be better, those things seem to control, but yet the lung is still progressing. So do you try to tease out pulmonary versus extrapulmonary and have that influence your decision on, I need more immunosuppression, or no, immunosuppression's done what it can, this is now more fibrosis and you just need to think antifibrotic?
I think if the lungs are continuing to progress, we still have immunosuppression as part of the algorithm, because ultimately they do need something to control their immune aspect of the disease. Yeah.
And how important do you think the blood markers are in guiding treatment, the inflammatory markers, or even just persistence of the autoantibody itself? Do those shape your thinking about treatment?
So in terms of the initial antibody workup, that helps with diagnosis and characterizing the patient, but less so with necessarily monitoring disease activity. The inflammatory markers can be helpful just in terms of looking at disease activity in certain patients. For example, in myositis, we will tend to also keep an eye on their CPK and aldolase just to get a sense of how their inflammatory myositis is controlled.
Fine. Yeah, we're not picking on you. It's not often we get a rheumatologist that we can just interrogate.
Exactly, our free consults here.
But I'll move away from rheumatology for a second here. So yeah, Kevin, now that we've got a third antifibrotic drug for IPF, do you think we should be persisting with monotherapy for our patients? Should we be using combination therapy? Is it one size fits all? How are you going to integrate nerandomilast into your clinical practice?
Yeah, so I think it's something we'll learn a lot. It's going to be an exciting next 6 to 12 months to really see how this plays out. I think I can think of 3 or 4 groups as I've tried to play this out in my mind. I have a newly diagnosed patient with idiopathic pulmonary fibrosis, has never been on therapy, can present all the options, but it's hard to imagine a scenario where they won't want to be on nerandomilast up front because of good efficacy and better tolerability. Super easy for those established patients that have failed both antifibrotics. We now have something that they've been waiting a long time for. The last 2 groups, I do have a group of patients that are on antifibrotics. They've been able to maintain therapy, but some of them are really, really miserable. And I can see switching those patients because they've just been waiting for something, but they've been putting up with side effects. And then there are those patients that we don't talk a lot about, but they're out there that are on either nintedanib and pirfenidone. They're tolerating them well with minimal or no side effects, but yet they continue to progress. And I think that's the group where combination therapy makes the most sense, at least initially.
Yeah, I know.
Curious, your thoughts as well?
No, I would fully agree. And I've had a list of patients who've been waiting for the approval who fall into particularly those last two groups of yours, the ones that have been on 100 milligrams twice a day of nintedanib and they're still having diarrhea, who are desperate for another option, and they will be switching. And then the ones who have been inexorably deteriorating but tolerating therapy. And those were the sorts of patients we had in the clinical trial. And certainly in the clinical trial, my patients who were on background antifibrotics tolerated the addition of nerandomilast well. I think it'll just be a case of us seeing from clinical experience how that approach works and whether we need to fine-tune it, whether there are nuances, whether there are ways of better selecting patients early on. Because the other question is whether we should ultimately be using upfront combination therapy, but I think we're a little way away from that.
Yeah, that's what I was going to follow up with you. So you've started that naive patient on nerandomilast. They get on it for a period of time, they're tolerating it well. The question will be, do we monitor for further, or when do we start combination therapy?
Yeah.
And which one? So
Yeah.
A lot to learn over the next year.
Good. Let's pull up another question. What would be your view on the Fibroneer IPF data and the interaction with pirfenidone? Do you think we should be using the combination of pirfenidone and nerandomilast?
So we can use the combination, but only at the 18 milligram dose of nerandomilast, because as you pointed out, at the 9 milligram, it's basically like a placebo because of the drug-drug interaction. So at 18 milligrams, yes, I think it's fine to use that combination, particularly in those patients that may be tolerating pirfenidone, but not at the 9 milligram dose.
Yes, and I think it's worth saying the FDA have approved the 18 milligram dose as essentially the first-line dose for all patients, with the option to step down to 9 milligrams for patients who are not on pirfenidone. If they are on pirfenidone, then the 9 milligrams is not going to work. So, a question for both of you. In a patient with systemic sclerosis and ILD involvement from the onset, would you recommend starting immunomodulatory and antifibrotic therapy simultaneously at diagnosis?
So typically I have not done combination upfront therapy, but again, I'll start them on mycophenolate, for example, and then continue to watch their ILD closely with serial PFTs, and then would consider if there certainly is some signs of progression, adding on an antifibrotic. Yeah,
our approach has been very similar, primarily driven by tolerability issues with the GI side effects, both with mycophenolate and nintedanib. Usually try to treat the underlying disease first with immunomodulatory agents, and then watch closely for the need of adding antifibrotic.
And I think we'll take one more question, which is related, which is relating to all fibrotic ILDs, I think including IPF. How early would you start antifibrotics? Would you start them in an asymptomatic patient? Is there anything that would influence your decision-making, like a family history or anything like that?
Yeah, I think we highlighted earlier that there's such a lag in diagnosis, and during that lag time, patients progress. So once you have ILD, I think the odds are that you are going to progress, particularly if we're talking about idiopathic pulmonary fibrosis. I guess that's where it makes the most sense. It's a progressive disease. You may be found early, which would be great. And the earlier you can start slowing down the progression, the better. You can certainly factor in other nuances around that. Sure, a strong family history, younger patients versus someone who's decades older, maybe won't have as much long-term benefit. So I think there's nuances around that, but I think in general the thought is, with idiopathic pulmonary fibrosis, it will progress, and the sooner you can slow that down, the better for the patients in the long run.
Perfect, I would agree. Right, I think we will wrap up there. Hopefully you all agree it's been an exciting session. I think we've covered a lot of ground in a very short period of time. Hopefully everybody feels slightly more informed about fibrotic interstitial lung disease. From my point of view, having a rheumatologist in the room has been an added bonus because as pulmonologists, we have the same circular conversation all the time. So to have a different perspective, I think is very important, and again, speaks to the importance of a multidisciplinary approach to treating our patients. So hopefully you've enjoyed the meeting. Please submit your post-test evaluation. Just as a reminder, any questions about the three of us, we were brilliant. Just to help you with the feedback. You can also download the slides and the practice aids online. And one of you lucky people will have won $50. It's going to appear on your phone, I think. And you can see one of the peer review team and claim your prize. Yes, here we go. Coffee will be on you. But thank you all very much for joining us, and have a great rest of the conference.
Yeah, thank you guys so
Thank
much for
you.
coming so early and for the questions.
Thank you.